Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinions, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, yours and ours, challenge the status quo, and explore what it truly means to thrive. I'm Dr. Santoshi Bilakota.
And I'm Dr. Shalom Morfell.
So let's get into it. Today's topic is a very important one. It is unpacking the primary care physician shortage that's going on at the moment. And so to start this episode, Shala, I'm going to ask you a question. Do you have a primary care doctor?
Now I do, but I didn't for a while. I had an issue that I wanted to be seen for. And so when I looked up the list of the providers or the physicians that I have access to through my insurance, basically there were none. All of them were APPs, NPs and PAs, and then resident clinic. So I ended up going to the resident clinic, but I wasn't happy because I found out that the resident was not even basically presenting the case the same day to the attending. And me being a physician, know that there were certain labs that needed to be done for my complaint. So he wasn't very understanding of it. And I said, did you present the case to the physician? And they said, oh, we don't do it the same day. So I was shocked and surprised. During residency, whenever we were in clinic, we would talk to the patient, get their complaints, form our own diagnoses and assessment and plan, and then right away talk to the physician and attending and present the case. And then if there's anything missing from our presentation or diagnosis or assessment and plan, then the attending physician would add to it. And then so it's more complete and it's with oversight. But I found out that was not the case when I had a complaint. So, but the resident ended up adding those labs anyways. The complaint remained. So then I had to really kind of pursue seeing an attending physician and internal medicine with internal medicine specialist basically to be able to address my complaint, which was better. But it took months. It really took months.
Same story. Actually, I don't have a primary care doctor right now, which is kind of embarrassing for me to admit because we're doctors. We're supposed to care about our health and our well-being, but I don't. Thankfully, knock on wood, I haven't had any big issues come up where I needed to get basic labs and stuff done. But of course, that's necessary, right? I think just to check even like a basic LDL level, I think at our age would be necessary, an A1C, things like that. I will say that I have a very good gynecologist, which as a woman, I think reproductive health tends to be the big thing. And she usually does all of that lab work for me. But, I think I want to get a primary care doctor. It's one of those things, however, that even though I live in New York City and it's such a huge density of physicians, it's almost impossible to find a primary care doctor. And like you said, it's a majority APP, which I don't have a problem with as long as there's some physician oversight. But it's really been a challenge. And then when you finally find someone, a lot of them, aren't on par with your insurance. So it takes a period of time. And again, like you mentioned, we're in medicine, so we actually can navigate the system. I can't imagine how it is for people who don't have that knowledge.
Exactly. And I know my friends and my even my husband had the same issue. He had a complaint that he needed to be seen for. And again, he had to go to a nurse practitioner to be seen in a timely manner. So it's a really widespread issue. And so that's why we're talking about it and we're addressing all these shortages and why the shortages exist.
I think, one other thing to keep in mind before we start this is I think primary care physicians are the backbones of society in terms of healthcare, right? They're the preventative disease specialists. Like if you have a good primary care doctor, you're not going to have all of these chronic illnesses that cause other issues later on in life. But because we have been unable to invest in our family medicine doctors, I think that's why we, as specialists, as neurologists, see so many people with really bad vascular disease, multiple strokes, really bad diabetes, LDLs that are out of control. I think if we had a better system in place where people could access primary care medicine, we would actually diminish a lot of these chronic health problems and these catastrophic events. So let's start a little bit by defining what primary care is. I know I mentioned family medicine, and family medicine folks, I have a lot of respect for them because they see patients from birth all the way to death. And that's a huge breadth of knowledge. I can't even imagine the detailed amount of training that they get, but they're able to see newborns, they're able to see pediatrics, middle age, adolescents, all the way to the geriatric population. So when we think primary care, usually that's what we think of. However, internal medicine folks also serve as primary care practitioners, and pediatrics as well, because that's also necessary if you have children. So that's their specific primary care doctor. So I think those are the primary care people or primary care physicians we're going to be focusing on in this episode. And I really think they are the front line of the healthcare system. So let's talk about some of this data. The AAMC, the Association of American Medical Colleges, projects that there is a shortage of 17,000 to about 50,000 primary care physicians by 2034. That's a huge shortage. And that's around the time, Shala, that you and I will definitely need some primary care physicians. Over 100 million Americans already live in an area where there's a shortage of primary care professionals. The AMC calls these HPSAs, which I guess stands for Health Professional Shortage Areas. The Health Resources and Services Administration also reports that the US needs over 17,000 more PCPs right now, today, right now, to eliminate these shortages. So I believe this number because we see it. How many times do we see patients in like a neurology setting and we ask them to follow up with their primary care doctor and they look at us very confused all the time?
I mean, we hear it from, we hear it from the patients and we see it. So, you and I cover inpatient neurology services. And how many times have you had a patient that says doesn't have a primary care physician and they're back to the hospital, right? To the ER, to the emergency room to get the care they need. So, and between, like, for example, for seizures is a big one, right? My recommendation would be to see an outpatient neurologist. But not only there is no outpatient neurologist, they don't even get to see their primary care physician or any primary care physician before they return to the hospital for the same complaint.
Exactly. Delays of weeks or even months just to get basic appointments. Yeah, weeks if you're lucky. We put in our notes, follow up in 4 to 6 weeks. It's like, where's that happening? It's usually 3 months or more to just even get the basic appointments, especially if you're in rural or underserved areas. So let's talk about why this is happening, right? There's a few reasons why this is. So one of the big reasons is a lot of the PCPs who are actively practicing right now, more than about 40% of them are nearing retirement. So they are retiring. And I think these were primary care providers. I don't like the name provider, I wouldn't say this, but there were primary care doctors who were family doctors in like the golden era of medicine. These are the people that people thought of, like the old man that your whole family saw, from your child to your husband to your grandparents. That's I think what that generation was, and a lot of them are retiring. And as they're retiring, there's not enough bodies to replace them because only 25 to 30% of medical graduates go into primary care for many reasons that we'll talk about. But a big reason is they're just very undercompensated. It's not big news that primary care people aren't getting paid well. They're undercompensated. Oftentimes they are overworked. And because of that, a lot of medical graduates want to specialize. They'll do internal medicine and then they'll specialize in something else. Even if they do family medicine, they'll specialize in something like sports medicine and, do that specifically. And so now we have a bunch of specialists and not enough generalists.
Right. And even some of them who don't formally specialize, I've seen that they basically see specific niche, for example, specific dermatological complaints or specific sports medicine complaints, as you said. So because it's too much to do just primary care, and they are overburdened by many other things like electronic medical records, long hours of work. You have view alerts that you have to, basically hundreds of view alerts, labs, messages that you have to respond to in between seeing patients. So, multitask at a level of a, robot, basically. It's very difficult to pay attention, undivided attention to your patient sitting there. And you're like constantly thinking, how many million other things that I have to do, right after this. So that sense of having your primary care physician who is sitting there and listening to you and asks about your children and asks about your parents and asks about your life and where did you go on vacation and how you're doing, it doesn't exist anymore. The primary care physician who is now, there more of them are retiring, those used to even round in the hospitals if their patients end up in the hospital for any reason. Again, it's very different structure right now, and I feel that I don't want to say compassionate element, but some human element of being a doctor is missed because of the current healthcare system. It just doesn't allow it for our primary care physicians, unfortunately. And so a lot of them are leaving the field because it's impossible for them to survive in this setting.
And you hit the nail on the head when you talk about compassionate care. There's a few elements that are necessary to retain compassion, right? First of all, you need time. You need the time to be compassionate. And I feel like, unfortunately, in a lot of these primary care settings, people are being forced to see 20, 30 patients in a day, which, ooh, as a specialist, I can't even wrap my mind around. That's a lot of patients, but that's the normal story for a lot of primary care offices. Also, like you said, administrative burden, Epic, you'll keep dinging for new results. I know sometimes on social media, I see primary care doctors putting screenshots of their Epic inbox. It's like hundreds and hundreds of stuff. And by the way, none of this is compensated, right? You go home and you take care of it, or you come in early and you take care of it. As a physician, your value is based on what you produce. For some reason, every other job has a value on time spent, but not us. We only get paid when we're producing something. So for some reason, all that documentation, all of that result review isn't compensated. So 53% of PCPs report burnout, according to Medscape, a Medscape survey in 2023. I think that's grossly underreported. I think a lot of them, more than 53%, are probably burnt out. And again, I think that's because they are overworked, they are underpaid, and the escalating amount of administrative burden also does not make that job appealing.
Yeah, I totally agree. And this kind of leads to worse outcomes within the patient populations,
Hmm.
especially underserved, vulnerable populations, low income population, elderly patients. That leads to higher ER usage, misdiagnoses, and that leads to more costs, more healthcare costs. Even though we are living in a developed country, but the healthcare cost here is significant, is significantly higher than other countries. So a lot of these problems lead to that.
Exactly. And I think it's important to add that a lot of these primary care positions, because there's a physician shortage, are being replaced by nurse practitioners and APPs. And we've touched on our prior APP episodes that there's a variation in terms of training in the APP world. A lot of the times, you're not going to get the seasoned grad who's going to be staffing these primary care offices. It's often going to be a new APP, someone who just finished their training. And unfortunately, you're going to have higher rates of misdiagnoses, higher ER usages, because they might not feel comfortable and they might just say, hey, go to the emergency room, right? And overall, worse outcomes. And I'm not saying that to say APPs should not be doing primary care. I think that's a great place for them. But what I'm saying is there's not enough physicians to train them properly. And when that happens and you're just introducing someone totally new into the world and they're seeing these people with 10 chronic health conditions, it would be hard for any of us to manage that in an efficient and proficient manner.
Right, I agree. APPs are very helpful, I think, in the primary care setting, especially area in underserved areas and rural areas. But I still think that at least in the initial stages after their graduation, they need oversight by primary care physicians so they don't miss anything. So I think we talked about this in specifically in our APP episodes. It helps with the shortage, but there is a physician still there who needs to educate them, who needs to train them, who needs to mentor them. And if those physicians don't exist, then leads to more delays and leads to misdiagnoses, safety concerns even. So all in all, it's not, we still need PCPs or physicians. And there was a survey, a JAMA study, that showed every 10 additional primary care doctor per 100,000 people increases life expectancy by 51 and a half days. So really lowering mortality. This is huge. So that's why we really need primary care physicians.
And this mostly affects the vulnerable populations, the lower income patients, the elderly folks, the people living in rural areas who are especially at risk because they can't access continuous care. And so, what do? They don't. And then you find yourself in the hospital with some catastrophic stroke or coronary event, and it's very unfortunate. We've also noticed that a lot of doctors are switching to a direct primary care model. A lot of primary care doctors are switching to a direct primary care model. And, I think it'll be helpful to talk about DPC further in another episode, focusing on the different modalities of medical practice. But I do want to briefly mention DPC because we are seeing a rapid growth in DPC. A study found that there is about a 13% growth since 2020. And once established, a DPC practice is a recurring model that seems to show efficacy and also shows a stability for the physician. And specifically, that study, and I'll cite the study in our captions, show that there's a 54% reduction in emergency room claims, 25% reduction in hospital admissions, and 13% reduction in total cost of claims in one specific DPC community that the study looked at, which is huge. 25% fewer hospital admissions, is great. So that's something to consider. So DPC is what primary care physicians are moving more towards, and we'll talk about it in a different episode, as I mentioned. But I do think it's important to highlight the existence of DPCs because that is becoming a more viable model for a lot of patients to access direct primary care. I will say it's hard to afford or justify affording a direct primary care on top of already paying your insurances, because for those who might not know, the way DPC works is it's a fee per service. So you'll pay a membership, whatever the membership is, to have unlimited access to a family physician, which is helpful because you can see them for 5 minutes or you can see them for 90 minutes. You can access them at any given time for a flat rate. So people often end up saving money by taking care of themselves. However, you still need insurance for catastrophic events. And with the way our financial situation and economy is set up right now, it does become very, very difficult for patients to justify that cost.
Right. But I'm hopeful that with that model, the PCP can get a lot more for what they do, right, from this membership fees. So I'm hopeful that once they see the compensation from this work is good enough, then and they have the autonomy to do whatever they want, they'll be able to subsidize for the less vulnerable in the society. Because right now, hospital administrators or others, it just gets to a point of really being greedy. Their paychecks are increasing and they're being compensated more and more and more, and they want more productivity from the physicians and just putting them on more and more pressure. But in the DPC model, when someone has the autonomy, has the time, and also making good money, then they'll be able to subsidize for the less vulnerable and help the less vulnerable also. It may not be, the same as the hospital setting, the same amount of people, but it's something, right?
It's something. And you made a very good point. A lot of the direct primary care physicians that I've talked to are doing a sliding scale for patients with economic need. And they can do that. That's the important portion, right? They can do that because they're otherwise being sufficiently compensated with their other patients. So I do think that is something we'll see more of a growth in as we move forward. Now, in our last few minutes, I think let's talk about some of the solutions and what needs to change for us to address the primary physician shortage. I think one thing, is expanding the residency slots for PCPs, so family medicine, internal medicine, pediatrics. The one issue with expanding residency slots is I also think you need to offer some incentive, because I do know that the currently existing residency slots aren't always filled because people are not too eager. A good incentive would be a financial incentive, right? PCPs earn 100 to 200,000 less per year, and I think that's an underestimation compared to a lot of the specialists. So really, there's minimal financial incentive, or you need to offer like loan forgiveness for people who are doing PCP work. And I think a lot of medical schools do have, and a lot of programs have that program in place, where if you're a primary care doctor and you work in a rural setting, you'll have some amount of student loan forgiveness. I think that, I mean, that applies to most physicians, but I think specifically there are some pathways that you can pursue. However, the way PSLF is going right now, who knows what'll happen there. But I think those are some of the few incentives we can offer to fill the residency slots that we do have.
And then in the attending world, I mean, there has to be more support for admin burden. You incentivize physicians or PCPs to stay in their jobs and not leave. Some give them autonomy, give them help with the view alerts. So basically, a lot more support. They give them admin time, so they don't have to do these view alerts in between patients, and they can have undivided attention, pay undivided attention to their patients. A lot need to happen to improve this.
Right. And one way to reduce admin burden is having support of medical assistants, which all clinics, I think, are short on medical assistants. And the reason for that is medical assistants are not paid very well. And two, they're also not treated very well by patients. When patients are pissed off, they're going to direct it at the medical assistant before they direct it at you. So it's kind of a thankless job. So if you want to retain a good medical assistant, you have to pay them well. And you have to give them a reason for staying. However, I think, unfortunately, a lot of health systems don't find that, or I don't find that they are investing in their ancillary staff, because doing that would actually make your physician's life a lot easier, and help patient care overall. But for some reason, they just don't have that tertiary level of thinking. And then, I think when you have a good medical assistant, they are going to help your burnout because they can help set up your prior auths, fill out those forms. A good IT support is also helpful. That I think is part of ancillary staff. If you don't have good IT support and you're doing telehealth primarily, that's important, because your physician shouldn't be the one troubleshooting IT issues while they're also trying to work. And I think team-based models, like we mentioned, APPs, I think are a great addition to primary care, but the physician needs to have the time to train them well. So all of those things are a few things I think that can be solutions. However, I don't think we're going to get there anywhere quickly.
Yeah, and telehealth is another one. I think telehealth is a good solution to expand care to the vulnerable and underserved areas. Technology is always a problem. Some of these areas or some elderly patients have more of a trouble with technology. They may not like it. Overall, I think especially after COVID, it brought kind of expansion of care model to our practices, all of us, even including neurology.
Exactly. And so, we encourage our listeners to support organizations pushing for expanded funding and access. And I can link the Direct Primary Care Alliance in the caption so you guys can check them out. But it's also important for you to advocate on a legislative level. Talk to your lawmakers and vote for policies that invest in preventative care specifically. And support any outlet that will also support physicians, like our podcast. And there are multiple other outlets out there that do help with physician and healthcare worker advocacy. And I can mention a few of those in the caption as well.
Yeah, I mean, we don't just need more doctors. We need a system that values the kind of care that primary care physicians deliver every single day, right? To every single
Exactly.
person.
Definitely something for us to keep in mind, especially as we are getting older. I mean, not only us, our parents are getting older. Like, who's going to take care of them? And then I'm really worried for when we are in our 70s and 80s. I don't even know what the healthcare landscape will look like.
I think a lot is changing, especially with AI, and we can have another episode about AI in medicine. So stay tuned. Thanks for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, and rate this podcast. Share it with someone who needs to hear this. Stay strong, stay empowered, and we'll see you next time.